Good afternoon and welcome to today's program titled Rethink Lost Revenue, Realize a Better Patient Experience. My name is Amanda Schiavo and I'm the Finance Editor for Health Leaders and your moderator for today's webinar. Today's program is sponsored by Cardinal Health. Thank you to our sponsor and to you and our audience for giving us your time and attention. Our program will be 60 minutes in length. Note that an on-demand version of this program will be available approximately 1 day after the completion of the event and can be accessed using the same login link that you used for the live program. Before we get started, I have a few housekeeping details. First, to ensure that you can see all the content for the event, please maximize your event window and be sure to adjust your computer volume settings and PC speakers for optimal sound quality. Second, you'll find a resources list for today's webinar in the lower right of your screen. Here we have listed the webinar slide deck and other materials from our supporters for you to interact with. Third, at the bottom of your console are multiple widgets you can use. To submit a question, click on the Q&A widget. It may already be open and appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program. Should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. Finally, it's my pleasure to introduce our speaker for today's presentation, Laura McIntire-Hansel, Director of Revenue Cycle Development for Cardinal Health. Thank you, Laura, for taking the time to speak with us today. And with that, the audience is yours.
Thanks so much, Amanda. I appreciate it. And hi, everybody. I wanted to start off by reviewing the agenda for today's discussion. We'll be going over why standard practices are not currently meeting today's industry need. Also be exploring payer barriers to the remit process, as well as why it's important to get into the game sooner, and being a revenue cycle partner to alleviate administrative burden and reduce rejected and denied claims. Finally, what results are possible and how you can get started. Want to take a moment and introduce myself. I'm Laura McIntire-Hansel, Director of Revenue Cycle with Cardinal Health. And I want to give you a little bit about me personally. I've been a healthcare professional for over 30 years, a nurse by training. And at times in everybody's life, we have kind of those watershed moments, or we have those things that change our perspective. And I had one of those about 20 years ago that allowed me as a healthcare provider to be able to look at things from a different perspective. I received a diagnosis that put me on the other side of the table. I was the patient. And through that personal experience, I truly came to realize how fractionated our healthcare organization and practices were. It was extremely frustrating from somebody that was a healthcare professional not to know how to overcome these challenges or where to turn. So as I continued in my healthcare experience and I went into working in specialty oncologies and rheumatologies, I was continuing to see my patients experiencing these barriers with prior authorizations and denials and not being able to meet the need and experiencing financial toxicity, things that were barriers for them to be able to achieve care. And then from a healthcare perspective, seeing our revenue cycle and being part of that, not being able to affect a change and being able to meet the need that our community was having. So even as a nurse, I felt I had a lot of these answers and was prepared to do a lot of these things. I found out I wasn't as prepared as I needed to be. So I went back, and this dates me at the time, into the ICD-9 coding world, and now I'm currently in ICD-10. And then went back again to gain further knowledge in the billing practices that is happening specifically in outpatient specialty revenue cycle, how it differs in each of our areas, whether it be large IDNs or small community-based hospitals or critical access rural health. Each of us feel those pain points, but we feel them each a little bit differently. So I really set about the process over the last couple of decades to develop an industry-wide solution that takes what was the fractionated nature of what we're dealing with every day and begin to put those pieces back together in a way that allows us to really re-engineer and look at not just a better patient experience, but another way to look at our revenue cycle that puts us from being, well, what in a lot of cases today is reactionary, to really being guides or to being setting out our own path for a better outcome. So with that, I'll kind of launch into the first portion of what we want to talk about, is why standard practices today are no longer meeting, industry needs. What are our barriers? What are our problems? So today we're experiencing 20% increase in denials rates in the last 5 years, year over year, and maybe in different areas and in different places. There's things here that have changed our world. 5 to 10 years ago, biosimilars weren't the presence in the marketplace that they are today. White bagging was barely even heard of, let alone clear bagging, alternatives, some of these other things that are being barriers to our revenue cycle. Now, something that hasn't changed in our world, and it does continue to go up, is rejected and denied claims. Right now, the average is 10% of claims face initial rejection and denial. Now, this is before back-end practices, scrubbers, and reworking, but 10% is a staggering amount. We often think that they're unavoidable and unpredictable. But really the case is there's a lot that we can do, and it's all about where we get involved to be able to mitigate those outcomes. Now I want to pause and talk about, we definitely have 2/3 of these rejected and denied claims that we experience in the revenue cycle. We are able to go back through standard practices, get them overturned, get them corrected, and rebuild them. But one of the things I want to point out is every time that we have to pick them up and retouch them or provide additional one-off handling or unique operations, it further erodes at what oftentimes is an already tenuous profit margin. And in some cases, our staff are overburdened to the point that these aren't picked up and worked, or there isn't a clear line of sight or path for a corrective action. So in a lot of cases, these go without resubmission. And this is part of what helps populate that unreimbursed care and denial percentages that we have in our facilities every day. So we'll go on to talk about the status quo and kind of how it's fraught with some inefficiencies that are precipitating some of these problems. That clinical validation and denial, this one takes up 18%. 20% are front-end issues, whether it be, the correct insurance, wrong middle initial, or any of the million that we could name. A large percentage are coding errors. A lot of people or a lot of areas in our organization are facing denials for or lack of medical necessity in Medicare for things previously we haven't experienced. Now, some of that is due to changes in what Medicare allows, that changing from the NCCN and the LCD and NCDs that happened a few years ago. Further, it goes back to some of the FDA requirements and as they change. But again, to highlight how biosimilars have changed our world and environment, these biosimilars, as they come into the market, don't always have the interchangeable diagnoses requirements or indications as their counterparts. And as this continues to change and evolve, it makes an already unclear perspective even murkier. The medical necessity and acute inpatient pharmacy issues, this is something that we've dealt with long term, but we're seeing increases in these numbers every day. These are only some of the reasons for rejected and denied claims. This doesn't even come in and start touching on the modifiers, the JW wastage, or some of the other modifiers or E&M codes that are being utilized in revenue cycle to be able to precipitate proper payment. So these are all very, very challenging, and it gets very convoluted in where and how we can use these. And in some of these cases, when we identify a problem, we might be able to course correct for the future, but we can never go back and change what's already happened. So there's a point in time where we have that loss of capturable return. So in looking at that, we then changed to look at payer barriers in the remit process. Now, we could probably spend a good long time talking about all of the things that are involved here, but some of them we see is site to care shift. In the last 3 years, I've seen a huge uptake in the amount of times that they're telling us that patient may be able to be seen once in the hospital outpatient setting, but after that, they're requiring by the payer to push to freestanding or home infusion. This is intensely challenging for facilities to be able to manage and keep on top of all of these ever-changing initiatives. Step therapy, to have to use one instead of the other, or the formulary alternative, or that you have to have a contraindication for this, that, and the other before you can use the drug of choice that's rendered by the provider. Again, knowing all these things ahead of time and not course correcting after the inevitable has happened is truly key to remaking what we're looking at. Medical necessity, we have listed here as a moving target, but that truly is a reality. Medical necessity for a given drug, and then you roll into what maybe the cancer compendium is say is allowable usage, and then third phase clinical trials or standard usage. Again, these are all coming back to the payer, saying at this point in time and this day and on this date, this is what we cover for this patient. We don't have the ability to be able to paint with a large brush and say in every case it will be this and not that. And it's that ever-changing target that makes it just a huge administrative burden to be able to keep up with. So we have questions around the queries that we have, coding query out to provider, timeliness of those coming back, and then how many do we have that are sitting out there that haven't been replied as yet? All of these are barriers to being able to submit claims and having them corrected. We have multiple stakeholders and numerous handoffs through this entire process. And every time we change from one to another, we have the ability for it to find a crack to fall into, or for that baton to drop and not be picked up. So the case study that I've put together here, the impact of treatment costs, to highlight what I'm talking about. So in this case, we had a 47-year-old female patient prescribed Remicade. So the insurance coverage and standard front-end practices, it was a commercial PPO. Pre-screening was done, and we were told that no prior authorization was required and that Remicade was on formulary. So through this process, the facility bought the drug, infused the patient, and went to bill. So the health system impact here is the first 3 infusions were denied as not covered because it was a site-to-care alternative, saying that they didn't have the right to buy and bill this medication, and it was required to be given through specialty pharmacy and third-party procurement. At the cost of this per dose, that's extensive for a facility. So through this claim process, or through the process that I'm speaking of, we identified the patient insurance that was contraindicated to buy and bill, that it had to be required through PBM third-party payer. Now, if there's internal usage for clear bagging and the facility has the ability to provide their own, obviously argue for that first and foremost. But if we can't, then being able to highlight in those areas that this has to be received from outside. So the facility now receives the medication via a specialty pharmacy to administer to the patient for ongoing care. But how we could have changed the spectrum of that is identified that Remicade had to have been procured from third-party payer, as well as partner some advocacy with that for the patients out of pocket, because what isn't highlighted here is they did have a $3,000 deductible. So all of those together, it puts the facility in a position proactively to identify how this would have a different outcome. So although the front-end practices that were in place for this patient initially, they weren't incorrect. The patient did have pre-screening done. Prior authorization wasn't required. It was on formulary, but it wasn't as highly specific as it needed to be to highlight the barriers to this remit process. So in this, we want to look at forgetting the rat race. And as I alluded to before, this is about a relay race. Looking at it today, rejected and denied claims are retouched 5 to 7 times on average. Now we look at that at about $181 in wages and corrective action on each one of those. But as we know, in the application of this, we have a denial come in or it hits medical necessity. We send an email out to a provider, wait 12 hours, 3 to 5 days, whatever it is for that to come back, to apply a different code, to submit it out again. So maybe at this point in time, we're at 60 days. And if there's still a problem, maybe we're at 90 before we get to patient balance. And at that point in time, it's 3 months from care and the patient's receiving a bill for whatever their portion of that was. So being able to look from the provider when the order is written, as it's gone through nursing and it goes to scheduling and intake, prior auth, and say it goes into pharmacy and pharmacy's like, oh, we have a Remicade. Formulary alternative says I should use infliximab, whichever biosimilar of choice. So that has changed. But what we don't have a line of sight to is the prior authorization was for the reference drug. So now we've affected a change because we want to save money as an organization, but now we lose 100% of that claim because the prior authorization isn't in place. And when it comes to revenue cycle, there's very little at this point in time that can be done with that. We had prior authorization for a reference drug, but a biosimilar was given. So we can see how at any point in time here, we can have a breakdown in the process. So this further goes to highlight how the standard practices of today aren't meeting the evolving and the changing need that the payers are putting in front of us every day. So what do I mean when I'm talking about getting in the game sooner? So a revenue cycle partner to help alleviate that administrative burden and reduce rejected and denied claims. So as we go to further explore that, I want to talk to you about what I see as the 3 pillars of uncompensated care, or the 3 stakeholders in hospital-held bad debt. Now we know that hospitals hold bad debt. I think the average right now is $5 million in lost annually per hospital in rejected and denied claims. So one of those first 3 pillars is the indigent and the uninsured patient. So there's programs in maximizing advocacy and replacement medications that are out there to help those patients. And that's wonderful. We utilize that to its fullest every day. But the second area that I want to talk about is that patient unpaid balance. If every one of us could look into our systems today as what's sitting out in pending due from patient, it's a staggering amount, whether it be 30, 60, 90, or 120 days. And ultimately, in a lot of cases, these are written off and sold to bad debt. And even if those are paid down the road, us as a facility, we don't receive benefit from that. So being able to maximize that second pillar of unpaid patient balance and alleviate any sort of a burden there is directly relationship and benefit to us as a facility. So the third pillar there is, we talked about that rejected and denied claims. And again, even though that 2/3 to 3/4 of those are pursuable and able to come to a paid balance, every time we touch those, further erodes at that profit margin. And when our margins are as tight on medication as they are, it can take us from making money in an overall percentage of a claim to losing money. And again, I talked about the fact that even if we can get 2/3 to 3/4 of these back, what about that 1/3 to 1/4 that kind of is left on the cutting room floor? That although we might have learned and course corrected for the future, 100% of retroactive analytics can't go back and change what's already happened. So the truth in this, and the true point that we need to get to, is getting into the game sooner and allowing ourselves to be in a proactive model for first time, every time, is what truly changes the course of our outcome. what I'm talking about is something that we don't often see in the marketplace. This is something that has a causative action effect on all three of the major stakeholders and pillars in hospital-held bad debt. Not just the indigent and uninsured patient, but patient balance as well. And talk about how that goes to patient experience, to be able to say to a patient that, yep, it might have been $2,000 copay, but I have assistance that helps with that. As well as looking at driving down the amount of coding queries our coders are putting out every day, reduce the amount of rework and claims that are being resubmitted. And that truly is what puts us in, again, a different perspective. So there's an industry average I was talking about that 60% of patients who don't pay their copay in outpatient treatment at time of discharge are end up written off for pennies on the dollar for bad debt. That's a staggering amount. Most of our facilities do not collect the patient anticipated portion of treatment in our Medicare and even commercial populations for outpatient infusion at time of discharge. I'm absolutely not saying everyone is that way, but in most cases, that is not identified and collected. So that's part of that 60% that ends up being written off to bad debt. So if we can use all practices to be able to identify and provide assistance for that 60%, that is definitely money well served for both our patient and our facility. So I put together another case study here so that we can kind of highlight what this means. So this is a 48-year-old patient that has an asthma diagnosis. They've been treated with Xolair. So the insurance is a commercial PPO. So initially, the patient was denied through their process because it didn't require prior auth on that pre-screening. But the claim came back as denied. It didn't meet medical necessity. Now, it was looked at, coding queries sent out, got additional information back in. About the 90-day mark, it was rebilled and paid because we went from an asthma unspecified to, asthma moderate to severe. So then we met that medical necessity. So it was rebilled, but then the patient had a $3,000 deductible, 20% out-of-pocket maximum in addition. So the allowable charge is in excess of $9,500. What made this further problematic is we had that annual insurance roll right in between first and second treatment, so it was like that perfect storm. The patient they made a payment arrangement. They had every intention of paying that, and life happened. They ended up one or two payments in and defaulted on the entire debt. How we can begin to relook at this as a practice is had we proactively been able to identify either copay assistance or nonprofit organization granting that would have covered that $9,500 copay for that patient, then we wouldn't have had to worry about the patient defaulting on payment because that had been in place prior to. So this highlights the impact of being able to have a holistic program that bridges that gap, silos, and barriers across the spectrum. So, as I said, why does getting in the game sooner matter? If you look at maximizing the ability to decrease rejected and denied claims, highlight a couple of things. So what if a doctor orders Avastin, but that payer won't cover Avastin? It's excluded on the plan. They only cover the biosimilar Zerobif. So being able to see that prior to the patient ever coming in so that you have a prior authorization for the Zerobif and the advocacy that matches it. Or if we're looking at a growth colony stimulator, making sure that the supportive medication diagnosis also has that upholdable presence inside coding guidelines and ethics to be able to be added to the claim. I know I put a lot of medication names in here in clinical aspect, but truly that's one of the magic portions of what we're talking about, is being able to have that clinical background from the medical side, as well as that coding background, as well as that billing background, to be able to bring that through the entire spectrum as a program to have a different outcome, to anticipate these barriers, to truly be able to identify savings from both industry programs, nonprofit organizations, charitable grants from zip code-based or other maybe faith-based organizations. Minimizing the time spent correcting those rejected and denied claims. All the coders that I've either managed or worked with over time, there's always more coding queries and rebilling out there than what we can get to in a day. So being able to optimize and use our in-house points of expertise to their highest level, where it's most effective, truly benefit for us as a facility. Now, for one system, there was nearly $130 million in patient balance sent to collections over a one-year period. Now, that's a huge amount, and clearly this was a large organization, but $130 million that processed through the dunning cycle, that went out to patient balance, that wasn't paid, that invariably got sold for or went to collections for bad debt. That's a staggering amount. Even if we could collect a portion of that through proactive means to be able to bring back into us as a facility, that really changes the game in what we're looking at. So the key elements in a proactive revenue cycle management process. Now, this is a partnership. This is not taking over anyone's revenue cycle at all, but looking at denial avoidance screening truly in that proactive to prevent the rejected and denied claims, the lack of medical necessity, the site to care change, the if I would have known I wouldn't have instances that we see in our world every day. Matching that with an extremely robust, non-traditional patient advocacy. And when I say non-traditional, looking at beyond just indigent medication replacement and recovery. Looking at our commercial payers as well as our Medicare payers, as well as those patients that are left such a high copay by their insurance that it meets financial guidelines that they would never be able to pay and qualify for free medication anyway. Or for those insurances that says I don't cover this drug or that drug. And then truly looking at supporting a biosimilar utilization and the prevention of uncoverable utilization and capabilities. And what I mean by that is I alluded to it earlier. As these biosimilars come to the market that don't yet or don't have a diagnosis by diagnosis adoption from their reference drug. So what if your facility as an organization chose to use Truxima a year ago? Anybody that you treated Truxima for RA would have been uncovered because it wasn't an indication that was payable by insurance. These biosimilars are going to continue to be fraught with challenges. And not to mention that our payers, even mid-course, are changing prior authorization guidelines or their preferred drug guidelines. I know in working with some of my biosimilar team and looking at them in some of our cases, we're having 45 to 50 changes in a given state area in a biosimilar market. I mean, how are any of us supposed to be able to keep up with those changes real time? The prevention of the rejected and denied claims really starts with that proactive process that stops the problem from occurring. To knowing on this day, on 4/27 of 2023, on Thursday, that this is the drug in line of sight for that payer for that day, for that time. Also looking at prior authorization and site to care shift and all of the other things that create barriers, again, in our world. That proactive partner that provides that support. So when we do get to our revenue cycle experts, they have the best chance to attain that clean claim every time. So looking at that proactive approach and rethinking how we're looking at the revenue cycle, I found by doing this that we can prevent that instance of that rejected and denied claim up to 80% of the time. And I know that's a large number, but it's really true. Looking at that in a proactive model knowing that every case, is it Inflectra over infliximab? Is it drug A over drug B? What is that formulary alternative that time? So the workflow efficiencies here, it minimizes time spent correcting those rejected, denied claims coding queries. I don't know a provider in the world that wouldn't appreciate less coding queries. I know from a nursing perspective, I would love not to do those. It's not like we're ever going to get rid of them, but, minimize them would be great. But one of the biggest things is relieving that administrative burden for that patient-centered on-site team that has other things to do other than to push papers or follow up on this or that. It truly is that back-end partnership that's key. So I've already talked about, and you can see how this decreases the bad debt. If we reduce the rejected and denied claims, obviously it's less held by the hospital. If we strengthen that revenue process by that unparalleled adoption of non-traditional advocacy, we're truly affecting that 60% of that unpaid patient balance that could potentially hit our unpaid books and being sold for bad debt. But from the nurse in me talking to you, it's supporting that care mission. It's decreasing that financial burden for the patient, remembering back when I was that patient. Enhancing that community reach to our patients and to our communities. I live in rural Missouri. So these are the people that I look at every day. These are the people that either kept me out of trouble or helped me get into it most of my life. I want to do whatever I can to be able to help the patients that I serve. So the solution that we put in place really enhances that handoff process between the stakeholders. And what I mean by that is when it goes from prior authorization for the Remicade we talked about earlier, and it goes to the pharmacist, and that pharmacist goes, oh, I've got an alternative that I can use the biosimilar. It truly puts a hand up in the air. It throws a flag up and says, hey, we can't use that here. We have to use the reference drug because the prior authorization is here. That pharmacist has the ability to go, oh, here that won't work. Okay. And then so we're not derailing the process. And that way, when it gets to revenue cycle, we still have the same drug that matches the same prior auth that matches the advocacy in place. So the program that we put together is HIPAA compliant. It's designed to work with any EHR because it is it's a people-driven solution. Now, we do have proprietary software that we use in the backside, but it is a people-driven solution. And it's a solution for right now, meaning it takes into account your stat orders, not just looking at what's happening upcoming, but for that lab value that comes back that we need to act right now. It has standard operating procedures in place to be able to approach those needs today. It works off remote access into EHRs. So through the Epics, the Cerner, the Meditechs, the Mosaics, the CPSI, it works with all of them through a customizable workflow practice that's really made in combination with each facility. Because if you know how a facility uses their EHR, you know how one facility uses their EHR. We're all very, very different. So I want to talk now about what results are possible and how you can get started in something like this. What does this really mean for the bottom line? So I put together a few things in a medium-sized healthcare facility because, I have no idea where everybody listening, what size this facility you're associated with. But a medium-sized facility that, say, has 4 hospitals. Your spend is anywhere in the outpatient side, 3.8 to 6.2 million is at risk for one hospital. Through a proactive comprehensive analysis, we uncovered for this given facility assistance support that provided checks cashed, $1.4 million of additional value. That's not just identified, that's all the way down to at a patient level, at a date of service level. So we looked at a 6-to-1 ROI for a proactive model. So the opportunity will continue to increase and has since I put this together through additional infusion clinics and sites And that's one of the nice things that is scalable about this program is even if it's just one facility as it grows, or if you have a specialist here and another specialist there, or you have a cancer center but the rheumatology center or the outpatient ambulatory. But we have that ability to be able to scale to serve all of that. So then when we look, say, at a rural hospital, say we're a 40-bed community hospital. In this case, we showed that they were $923,000 to $1 million at risk. Through the proactive comprehensive process we implemented, including a patient assistance program, we netted here a 5-to-1 ROI with a proactive model. We were actually able to drive down their percentage of clean claim, or drive up their percentage of clean claim. And they were at a much lower percentage of dirty claim than when it came in. So this increases the facility cash flow. It really supports cash on hand. And then it's also supporting for those on-site teams that allows them to have that administrative burden freed up to be able to provide a more patient-centered experience. So what are the results and what are possible, and kind of how can you get started? I would say internally, evaluate your current revenue process and your reimbursement process, really highlighting on things like how are you handling the biosimilars? What is the formulary adoption? Are you looking at purchase over remit potential and percentage in your high dollar medications? And what I mean by that is if you have 5 to 7 drugs in a classification, have you earmarked and targeted what drugs are upside down, meaning your reimbursement is never even going to match the purchase price to be able to procure it? So being able to highlight and identify those areas. So then secondarily, consider the organization's silos, your areas for improvement. Do you have a centralized scheduling? Is it directly in line with the ordering provider? Is there lines of communication between that alternative change out in the pharmacy and between your buyer and what's happening with your front-end registration staff? Again, looking at that in the clinical role into either in your nurses and then as well as your coders. Do you have the appropriate diagnosis codes in the EHR in line with those revenue cycle or coding requirements that can be added directly into the claim, further expediting that process? On the third part, assess your capabilities and your support needs. Do you have an infrastructure for advocacy? Do you have the opportunity to adopt greater practices? Or do you not have that and want to look externally for external partners to be able to provide those areas that you've identified as unique points to be able to improve? So as I kind of wrap up and we head towards a bit of a Q&A, I wanted to reach out to you guys and let you know if you want to learn more about this process, please, reach out to the www.cardinalhealth.com at Rethink the Revenue Process. I would love to spend some more time to be able to chat with you either directly or about your unique needs. So having said that, Amanda, I will reach out to you to see if we have any questions in QA or things that I can further expound on.
Great. Well, thank you, Laura, for that really insightful presentation. So like Laura said, this now brings us to the Q&A portion of our program. So we would now like to invite you to ask live questions of our speaker. As a reminder, to submit a question, click on the Q&A widget at the bottom of your console player. It may already be open and appear on the left side of your screen. Also, please note that your questions will remain anonymous and will not be viewable by other audience members. Okay, so let's see what our first question is. Are all medications for diagnosis or therapeutic class reimbursed similarly?
I think the easiest answer there is no. There are many drug classifications that have huge swings in between how they're reimbursed and the requirements used. So this adds a distinctly large wrinkle for if we have a buyer, like say in the world of IVIG, there's there's like 8 drugs in that classification. So you have some that are purchase price much higher than others. But here's the challenge. They're all remitted the same. So at least in CMS guidelines. So understanding and knowing what your remit process is, what that purchase drug that we're actually getting, that's what I call that evaluation between purchase price to remit, is truly knowing where that is.
Our next question, what if I already have front-end process to address these issues?
Well, I would say we all have front-end processes. Anybody that's in healthcare, we have front-end processes. You know, we're looking at, do they have insurance and do we have prior authorization? Here's what I find in a lot of facilities that I work with. We have fairly robust prior authorization processes for our commercials and some of our others. But what we don't have as robust is those things that are looking at our payers that don't have formal prior authorization processes, mainly our Medicares. And Medicare is one of our largest payer mixes. But yet we're not doing much of anything to look at the drugs that we have listed are in line of sight to payment. So case in point, we use the drug Venifer, kind of like, salt on our food. We use it everywhere. But in the Medicare world, it has to go by FDA indication. The FDA indication for this drug cites a 2-step guideline that in most cases we don't meet. We give it for iron deficiency anemia. We are not keying into the fact it needed chronic kidney disease as a secondary to truly meet FDA guidelines. Now, that's just one case. There are a million drugs that would have a lot of the same indications, that it's not just prior authorization. And as we saw in a couple of our case studies, we can call in for prior authorization and they say no prior authorization is required. But if we don't ask every question, site to care change, formulary alternative, exception, exclusion, do we have the right to infuse in hospital setting? All of these questions are hugely important to ask as well, because any one of these can prevent a barrier to the remit. I mean, there's many others, but that's kind of a highlight.
Can you give some examples of areas that are common problems with claims approvals?
Oh, absolutely. So areas of common problems for claim approval. So if we have, again, we can use IVIG, case in point. If we had an approval for a prior or approval for clearance for GammaGuard, but when the ordering at the pharmacy chose Privigen, but that was excluded. Another area can be a prior authorization that was either outside of the date range, outside of the unit range, or outside of the allowed visit date range. So 2 out of 3 were perfectly fine, but 1 rendered us unpaid. So there's other areas like the site to care shifting, that front-end practices and authorization said everything was good, but we came back, it's this site not covered. So again, front-end practices by their standard operating procedure asked all the right questions that they had, but we didn't get all the way down to what was going to prevent us from being paid. I hope that further answers the question.
Our next question is actually in 2 parts. First, what is a good denial rate? And second, what if my denial rate is only 8%? Is there still an ROI for my hospital?
Well, we did say in there that hospitals face an initial 10% rejected and denied claim. Now, I did say that this was before back-end practices, claim rework, coding, a lot of these other areas. Most hospitals don't end at 10%, or sometimes even at 8%. There definitely is an ROI for this program. The denial rate only takes in 1% or one quotient of this program. I would challenge to go back and look at that patient unpaid balance, to go back and look at the amount of indigent patient or excluded patient. Or if you have internal charity care, what percentage of that internal charity care could be pushed to other programs that would make that internal program stretch those dollars even farther? So there's always ROI for a program like this, even if you don't have the largest population or the largest number of denials out there.
If we already use a vendor's software to address part of the process, do we need to do anything more? And if so, is this approach complementary to other vendors' software?
Well, I would say that there's several things to unpack in that question. That's great. So if you use third-party software to address a portion of this, or if you use a third-party vendor to attach, say you outsource your RCM, your entire revenue cycle is outsourced. Or if you outsource maybe your underpayment percentage. So absolutely, this is complementary. So we would look at the front-end process to be able to drive down the numbers that were found as not paid appropriately, or be able to expedite. If you're outsourcing your RCM to an entire third party and you're paying a percentage, the amount of clean claim first time, every time will drive down the amount you're paying to an outside RCM perspective. So say you use other advocacy terms, or you have other advocacy players in place. To be able to have a more robust advocacy program that allows you to reach more benefit for your patient, it just helps lower the overall out-of-pocket debt load. It helps increase that patient experience. It helps your internal staff who, in a lot of cases, are already wearing 5 to 7 hats every day to be able to focus, to be able to work at the highest level of their license and expertise, to be able to have these things managed. So there is benefits for a program like this, irregardless of where you're at in the spectrum.
All right, well, that looks like that's all the time we have for questions today. I want to thank Laura McIntire-Hansel once again for an excellent presentation, and also thank our sponsor, Cardinal Health, for making this program possible. Finally, thank you to you and our audience for participating today. We hope you'll join us in the future for other health leaders webinars, and this concludes today's program.